Thank you so much, Mary. And a fine good morning to everyone. I have the difficult task of speaking after Francis Collins last evening. Wasn't that just a magnificent presentation? It really was. And we're all deeply indebted to him for his heart and wisdom and a real education. He did help me quite a bit in introducing much, if not most, of my talk. But I want to take up his fine challenge to us. And that is not just raise the questions, though I'll have to do some of that to place things in context, but also to try to come up with some policies, some solutions, some answers to these difficult questions and dilemmas. And so I hope today to at least throw up a few clay pigeons for you to shoot at. In fact, earlier this morning, the video people had this nice bullseye up here. I guess someone was centering in, getting ready for the question and answer session. Declare the past. Diagnose the present. Foretell the future. Practice these acts. As to diseases, make a habit of two things: to help, or at least do no harm. So wrote Hippocrates in his work, The Epidemics. Foretell the future. Prognostication is certainly part of the work and the duty of the healer. The explosion in genetic information provides us with an opportunity as never before to discern risks for the development of disease, not just to diagnose a present malady, but the ability to better predict or at least assess the probability of future illness. Clearly, this capacity has a potential for significant good. Genetic information can thus be like all medical information and all medical knowledge. It can empower the patient and the healer. To the individual who may be found not to possess a gene for a terrible disorder such as Huntington's disease or one of the so-called cancer genes such as BRCA1, may come freedom from anxiety or easier career and family planning. To those who possess one of these cancer genes, the knowledge may be of help in reducing other risk factors for subsequent cancer development. This could occur through increased medical surveillance, avoidance of environmental carcinogens, the use of chemo prevention, or the use of prophylactic measures such as prophylactic mastectomy, as Dr. Collins mentioned in one of the cases last night. It is this potential for good that makes genetic testing morally permissible. And further, I would quote from the Lord's word in Ezekiel 33:6, "But if the watchman sees the sword coming and does not blow the trumpet to warn the people, and the sword comes and takes the life of one of them, that man may be taken away because of his sin, but I will hold the watchman accountable for his blood." I think we are compelled through the long-standing principle of non-maleficence to reduce harm and to prevent suffering and injury whenever possible. Now, in spite of this potential for good, we must recognize that we live in a fallen world, a world in which that which can be used for good can also create harm. While genetic information may be helpful, it may also be an instrument of discrimination and prejudice, a source of fear and anxiety. Now, before we proceed further in examining these potentials for good or for harm, I would like to clarify a few definitions. Testing in this context is the application of a genetic technology to resolve a specific question for one individual. Usually there's a family history to suggest the individual is at some increased risk for a disorder. Screening, on the other hand, is the application of this testing on whole populations in the hope of reducing the impact or incidence of an illness on a larger scale. In screening, the individuals may have no family history at all, suggesting an increased risk. And while many of the concerns about the use of genetic information pertain to both screening and testing, there are also some significant differences. I will say that the majority of my comments will focus on the question of testing. Now, a genetic test must be evaluated as any other test. Its sensitivity, and its specificity, that is, its ability to detect the abnormal state when present or to discriminate the normal state when disease is absent, is absolutely crucial. When one is attempting to predict the potential risks of developing a serious or life-threatening illness, this accuracy is critical to the patient. With a well-known genetic mutation, direct testing will in time be able to produce 100% accuracy. However, many genes carry multiple mutations. There are over 200 mutations known in the factor IX gene, which would then produce the disorder we call hemophilia B. Recent studies have shown over 100 mutations in the breast and ovarian cancer susceptibility gene BRCA1 that Dr. Collins talked about last night. Some of these may be what are called neutral polymorphisms. In other words, they're mutations that have no clinical significance to the patient, while the majority of them may be very important in producing disease. With such a large number of mutations possible, the testing may not detect every case that could have clinical significance. This is brought home in what I deal with in coagulation with a condition called activated protein C resistance, which predisposes patients to developing abnormal clotting or thrombosis. And there is one mutation, the factor V Leiden mutation, which is responsible for the majority of cases of APC resistance, but it is not the only one. And presently, we don't have testing for the other mutations. We're dependent upon a clinical functional test, which is clearly limited and not 100% accurate. And so a negative test may not be truly negative if one possesses one of the other mutations of a disorder. The lack of 100% accuracy of a test does not completely invalidate its potential use for an individual, but it does require full and informed consent of the limitations of the testing prior to its use. However, when such tests are considered as screening tools for a larger population, there's additional cause for concern. Let me give you a hypothetical example to illustrate this. This is just all, again, sort of a hypothetical. And I did notice that there was a deletional mutation here, but I think it's one of those neutral polymorphisms that shouldn't interfere with what I'm trying to communicate. Now, this gene that we're going to be testing for has a prevalence of 1 in 200 in the population. At the present time, the sensitivity of our test, that is its ability to detect those patients with the abnormal gene, is 90%. The specificity, that is its accuracy in predicting the absence of the gene, is also 90%. Now, if we wanted to screen 10,000 individuals, according to the prevalence of the gene in the population, there would be 50 true carriers. However, with 90% sensitivity, only 45 of those carriers would test positive and 5 would falsely test negative. Given the 90% specificity, of the 9,950 who did not have the gene, 8,955 would be correctly identified as negative. However, of that same population, 995 patients would be falsely identified as carriers or false positives. Now, given the tremendous anxiety and possible inappropriate management this could produce, it's clear that for a test to be appropriately used as a screening tool, it must be as close to 100% sensitive and specific as possible. Now, another issue can also confound the reliability of this type of testing, and that is the penetrance of the gene. Penetrance is the rate of actual expression of the gene or abnormal gene, and not all genes are expressed 100% of the time. Therefore, a patient could test positive for a mutation, but not necessarily have to suffer the consequences of that mutation. We're still in the process of learning the rates of penetrance of some of the mutations that can now be detected, but it is for these reasons that testing for a breast cancer susceptibility gene or most other cancer-associated genes should still be considered experimental at the present time and not ready for widespread testing or screening, as Dr. Collins mentioned to us last night. Before a patient undergoes a test with all these potential ambiguities, he or she should be informed and be able to provide voluntary consent to the testing. Included in the consent process should be information on how the test is performed. Is there a requirement for other family members to be tested, such as in linkage studies? If so, what are the chances that those other family members may learn the identity of the patient or perhaps the results of the patient's testing itself too? What is the result or what is the specificity and sensitivity of the test? What are the implications of that? What is the potential to find out something else entirely undesired or unintended, such as non-paternity, which my colleagues in genetic counseling say occur about 8% of the time? What are the implications of the testing? What can or can't be done with the information? In other words, can we do something about a positive result? Will undesirable decisions have to be made or confronted with the use of the information, such as potentially a recommendation to proceed with abortion? What are the other implications, such as the potential for insurance or employment discrimination? This leads us into one of the most important questions in the area of genetic information and testing. Who should have access to this information? In addition to the patient, should other at-risk family members be notified of the results of testing? What about a potential mate? Should a parent have the right to obtain this information for their children? Employers have a need to hire employees who can best perform the tasks at hand. Should not an employer have access to this information if it could impact on the employee's behavior or reliability? Insurers have long been in the business of stratifying risk in agreeing to provide life insurance for a client or in assessing the cost of that insurance. Genetic information could be an extremely important factor in identifying future risk. Should not insurers have access to this information? Or as some would say, certainly if insurance is paying for the test, does not that give them right to that information? Does the government have the right to test potential employees, particularly in the armed forces, or those who are seeking public office, to determine if there's going to be any significant complications in the performance of the individual's duty? Or in the final analysis, should only the patient and their primary physician have access to this information? I think we must ask another more fundamental question. Is confidentiality an absolute principle? Can it even realistically be maintained in our present environment? Now, a long-standing tradition of medicine has been to protect the confidentiality of a patient's medical history. In the oath, Hippocrates stated, "And whatever I see or hear in the course of my profession, if it be what should not be published abroad, I will never divulge, holding such things to be holy secrets." This obligation may be even more important in the area of genetic information. There's already been a strong history that this information can and is used for discriminatory purposes. When screening for sickle cell disease was initiated in the 1970s, many African Americans with sickle cell trait, not the disease, lost their jobs or health insurance or were dismissed from the military when they were healthy and at no risk for developing problems. Billings and colleagues reported the results of a survey performed to assess the incidence and types of genetic discrimination that patients have experienced. A mailing was sent to a little over 1,000 professionals in clinical genetics, genetics counseling, disability medicine, pediatrics, and so on. And they received 42 responses, of which they felt 29 met sufficient criteria for further analysis. Of those 29, they listed 41 separate incidents of discrimination, 32 involving insurance, including application or coverages for health, life, disability, mortgage, and auto insurance, and 7 involved employment problems. Many of these individuals had undergone testing only because another family member had been affected with a genetic condition, but yet they themselves were still healthy. One patient with hereditary hemochromatosis, this is a disease of iron absorption and storage, which can be extremely well managed by occasional phlebotomies, that is, good old-fashioned bloodletting, was denied insurance, stating, "I might as well have had AIDS." Another case involved the brother of an individual who was found to have Gaucher's disease, which is a deficiency of a liposomal enzyme that leads to the buildup of a protein in some of the white cells of the body, producing a variety of clinical effects. The patient's brother was screened, and the results suggested that he was an asymptomatic carrier. The patient's brother applied for a governmental job and included the history of his testing in the application, but was denied the job because of being a carrier like sickle cell. This past April, a study from Stanford and Harvard universities was published, which received a fair amount of lay press coverage. 206 cases of genetic discrimination by businesses, insurance agencies, schools, blood banks, and the military were documented. Included among the cases was a situation in which a woman's HMO would pay for an abortion of a woman's fetus who carried a gene for cystic fibrosis, but denied coverage for the birth and care of the infant if brought to term. Another involved a social worker who was fired by when her employer learned that Huntington's disease affected a member of her family. And prior to that time, this worker had received excellent reviews and gone through 3 promotions. The authors concluded that nearly 50% of people who have a known gene that could predispose them to disease have been discriminated against. Now, this study has been sharply criticized by insurance groups, stating that it's purely anecdotal, and that the stories tend to come from disgruntled members of support groups for genetic diseases. However, if the anecdotes exist at all, it's tremendous pause for concern and reflection. Now, one approach to preventing this type of discrimination and protecting confidentiality has been to consider genetic information as different and separate from other aspects of the patient's medical record. Some institutions have therefore established secondary or sham histories to keep genetic information separate from the rest of the patient's medical record. Strict confidentiality, however, will be very difficult to maintain in spite of this maneuver, and I believe it can be correctly argued that this material should not be kept separate from the rest of the patient's medical information unless the information will not have any impact on the patient's health in any way. Otherwise, if the results of genetic testing are to be of benefit to the patient, they will affect patient behavior and potentially influence the course of care. If heightened surveillance procedures or prophylactic interventions are employed, there will need to be some notation in the medical record or the patient's history accounting for this behavior and justifying the interventions. Once so elaborated, maintaining confidentiality from insurers, other healthcare providers will not be possible. Even if not explicitly stated, the astute observer should be able to surmise the reason for various aspects of the patient's behavior and care. More fundamentally, I do not believe it's good policy to not include all aspects of the patient's health status in a medical record. All the individuals who may subsequently be charged with making healthcare decisions with the patient should have access to that material. If no record is formally kept in the patient's history, then the information may be inaccurately transmitted by word of mouth from the patient to other individuals. What will not be communicated may be the limits of the testing that was employed and cautions involved in its interpretation. If these things could be recorded up front in the patient's record, then there would be far less opportunity for misunderstanding and miscommunication down the road. Now, Melman and colleagues have proposed that genetic counseling and testing be done on an anonymous basis. And while there are some situations which we'll discuss where this may be appropriate, I believe that overall this approach in general is flawed for the same reason as having a sham history. If genetic testing has advanced to the point of producing a result that will be shared with the patient, I believe it should be included in the regular medical record. Now, Dr. Collins last night alluded to the fact that 11 states have anti-genetic discrimination laws of some kind regarding insurance or employment. And I think the solution to this problem is widespread universal legislation prohibiting genetic discrimination in insurance and employment. I think this is the only realistic opportunity we have to solve the problem, or at least try to curb it. Patients and physicians should not have to adopt dishonest or secretive behaviors which cannot succeed and are counterproductive to the overall care of the patient. Let's examine some other challenges to confidentiality. What about a potential spouse? Should he or she not have a right to information about their future partner's genetic status? As procreation is certainly a major emphasis of many, if not most, marriages, shouldn't the risk to potential offspring be known prior to engaging in the commitment of matrimony? Certainly, the type of disorder and the mode of inheritance will have an influence on potential solutions to this problem. For those disorders that are transmitted in an autosomal recessive fashion, such as cystic fibrosis or Tay-Sachs disease, one potential model is the Sheva-Dor-Yeshorim program created by the Committee for Prevention of Jewish Genetic Diseases. In an autosomal recessive process, the abnormality is not clinically manifest unless the individual has two abnormal genes. If a person has only one, the individual is a carrier, but they may not have any clinical consequence in themselves. However, if that person marries another carrier, each of their children has a 1 in 4 chance of inheriting two abnormal genes and manifesting the disease. 1 in 25 Ashkenazi Jews is a carrier of the Tay-Sachs gene, and another 1 in 25 is a carrier of cystic fibrosis gene. In the Dor-Yeshorim program, young men and women of meritable age are assigned a number. Their blood is then tested with the only identifier being that number. Names are not recorded. When a match is proposed, a phone number can be called, and the prospective couple give their two numbers. The couple is then informed of whether the marriage could proceed safely or if both are carriers, creating a 1 in 4 risk of a child having either Tay-Sachs or cystic fibrosis. To a close-knit community like the Orthodox Jews, this program has been helpful in preventing the labeling of tainted blood that could otherwise stigmatize young men and women. Only if both members of the proposed couple are carriers is the genetic status revealed, and then only to the couple. If the couple receives word of the risk and calls off the proposed marriage, no specific explanation must be given. I think that this type of anonymous testing could be acceptable because the carrier status has no influence on the remainder of the patient's health care, only on their decisions regarding marriage and procreation. The program has been extremely well received by the Jewish population it serves, and many dozens of marriages have been prevented that would have potentially resulted in great tragedy for the children and their families. This approach also has the advantage of not identifying disease status until after a child has been conceived. There is no temptation to terminate an innocent life before its birth, and consequently this type of program, I believe, is consistent with the Jewish and Christian reverence for life. Now, what if the situation were somewhat different? What if the patient had several family members with Huntington's disease, which is an autosomal dominant disorder, and testing showed the patient had a high probability of contracting Huntington's disease themselves? Huntington's disease is an incurable late-onset disease of the central nervous system leading to a devastating dementia and involuntary movements. Its symptoms usually begin to appear in the 4th or 5th decades. Now, this individual is going to get married soon. In discussions, however, you learn that the patient has not shared with the fiancé the family history of Huntington's, nor the individual's likelihood of suffering from the disease later in life. The patient states that they do not want the fiancé to know this information because he or she fears that should the individual learn this fact, then their proposed spouse would no longer want to get married. Similar challenge to the obligation for confidentiality could be envisioned in which an individual refuses to allow other family members to be notified of their potential risk and need for testing after that patient has been found to be positive for a genetic disorder. Is the obligation to maintain strict confidentiality in these circumstances, or is the caregiver obligated to warn the others of the potential risk? George Annis of Boston University and his colleagues have written in their proposed Genetic Privacy Act that no such duty to warn exists legally. And they would strictly prohibit any disclosure of genetic information to relatives over a patient's refusal. Mr. Annis writes, quote, "This no exception rule also maximizes the privacy between individuals who receive services that result in private genetic information in their health care providers. It also places the responsibility for informing relatives of their potential genetic risks on the family member who has such knowledge, which is where we believe it morally belongs. Further, we think it is reasonable to assume that with proper counseling and guidance from supportive and informed practitioners, family members will act in a protective manner toward other family members. Another author believes that trying to protect other individuals will have serious downstream effects. It will transform a right to disclose into a duty to disclose, and it will be hard to know where to establish legal limits to that duty. Consequently, any relative who has not been contacted could potentially sue the caregiver. Therefore, it is best to maintain a strict wall and not allow any disclosure to occur without the patient's consent. Now, while these arguments are strong and may in the final analysis be the most practical, I am not yet convinced that they are sufficiently morally valid. While I cannot conceive of a convincing or compelling moral argument for choosing to conceal information like this from a relative who could benefit from it, these cases certainly arise, and no amount of counseling will induce the patient to do the right thing in spite of Mr. Anna's optimism. The motivations for withholding such information are usually based upon selfishness, spitefulness, anger, or some other interpersonal conflict within the family, and none of these reasons override the moral requirement of preventing suffering or preserving life. I am haunted by Ezekiel 33:6. I agree that the family member has a moral obligation to inform his or her relatives, but as caregivers, I believe that we have an obligation to prevent harm and illness. We are the watchmen. Certainly in my field, it is far better to prevent malignancy than to attempt to control or cure it once it is developed. Now, acknowledgement of the difficulty in establishing legal limits to a potential duty to inform is insufficient moral justification to prohibit the rightful sharing of this information to protect known individuals at risk. Physicians have a higher moral calling than legal risk management. Confidentiality is an important principle, but it is not absolute. We go back to Hippocrates. He said, that which should not be spread abroad, implying that there are some things that should be shared. It is not an absolute obligation. And I believe that there are other competing obligations which issue greater moral claims than confidentiality. And one of these claims is the duty to protect and preserve life. In Jewish moral theology, only 3 laws are more important than the obligation to heal or save life: the prohibitions against blasphemy, adultery, and murder. This reverence for life is preserved in Christian ethics and I believe challenges us to act when confronted by a patient's irresponsibility. 2 groups have suggested criteria to identify those situations where confidentiality could be breached and relatives informed about genetic risks. The first, the President's Commission for the Study of Ethical Problems in Medicine and Biomedical and Behavioral Research in 1983, and the Committee on Genetic Risks of the Institute of Medicine in 1994. These groups have stated that relatives could be informed if, number 1, all attempts to elicit voluntary disclosure from the patient have failed; 2, there is a high probability of irreversible or fatal harm to the relative without disclosure; 3, the disclosure of the information will prevent harm; 4, the disclosure is limited to the information necessary for the diagnosis and or treatment of the relative. The issue of who to inform, I acknowledge, could potentially create a never-ending list, but I offer the following practical suggestion to at least consider. I believe it would be reasonable for parents, siblings, and offspring to be the main list of those concerned. This group comprises those individuals that are most likely to be affected, and if subsequent testing of that relative is positive, then those in a similar relationship to that individual could be informed, and so on. I request that my brothers and sisters in the Christian Legal Society and in the legal profession work with us in trying to establish that population and rules under which we could rightfully share this information with those that most need it. The finding of a genetic predisposition to a serious illness such as Huntington's disease or cancer can produce a tremendous change in a person's life and invoke significant emotional responses. Just ask yourself the question, how would you respond if you knew you had a potential time bomb ticking away inside of you? True, we all know that we're going to die, but given that basic fact, we still have tremendous concerns about how we will die. The thought of being transformed by a severely dementing illness or enduring the ravages of metastatic cancer are frightening prospects, even to those of us who know our eternal future is secure in Christ's hands. Studies have been done of the psychological and social consequences of testing for Huntington's disease. In one survey, 11% said they would consider suicide if found to contain the gene. 5% said they would commit suicide. It is already known that Huntington's disease patients commit suicide 7 to 14 times more often than the general population. 40% have stated that if they learned they had this gene, or 40% have had severe depression. Others develop sexual promiscuity and impulsiveness. In patients with a high susceptibility to cancer, either through familial risk factors or through genetic testing, strong emotional consequences occur as well. Lehrman found that of a group of 121 patients with first-degree relatives with ovarian cancer, 80% felt they would become depressed if they were found to have a positive test result for BRCA1. 32% said this information would dramatically impair the quality of their life. And Cash et al. Found 27% of women at high risk for breast cancer experienced psychological distress consistent with the need for counseling. Interestingly, as Dr. Collins illustrated in a case he shared last night, negative results of testing can also induce significant emotional and psychological problems. 10 to 20% of patients who are found to be negative for Huntington's disease had such problems. Some arose because the patient now had to confront decisions that they had made when they assumed they were going to get the disease and now found they had to live with it for the rest of their life. But others had this phenomenon called survivor guilt that Dr. Collins talked about. Lehrman found that 25% of women with a mother, sister, and or daughter who had a history of ovarian cancer indicated they would feel guilty if they themselves were found to be negative for the BRCA1 gene. Because of the potential emotional consequences, genetic testing must always be voluntary and informed. In addition, this also places an obligation upon the providers of such testing to ensure that adequate counseling is given before and after the testing and is available to deal with the negative consequences should they occur. We are then confronted with questions which Ms. Elizabeth Thompson is going to address about the whole area of counseling. Can it be non-directive and so on? Now, earlier on, while discussing informed consent and genetic testing, I referred to the need to discuss the potential implications of genetic information. Jose Alberto Menete wrote, "Diagnosis is not for knowledge's sake, it is knowledge for the sake of action." What are our obligations to act upon the results of genetic testing? Is there an obligation to not procreate? Linus Pauling has stated, carriers of cystic fibrosis who have children add to the amount of human suffering and should feel guilty for their actions. As Christians, we can reply that every life is precious regardless of its genetic constitution or physical affliction or impairment. I therefore do not believe that any strict obligation to not procreate can be forwarded. It is between the individual and God to determine if having children is desirable. To the Christian, there is no such concept as wrongful life. And we should resist any policies of forced or coerced testing, sterilization, or abortion. Testing in the decision to not bear offspring may be wise or desirable, but it cannot be mandated. This brings us to one last group of individuals that might potentially want access to genetic information of another: parents. Should parents be able to have their children tested for genetic predisposition to various diseases? Can a parent have their child submit a specimen for linkage analysis to assist other family members in diagnosis? If the testing will lead to interventions that can benefit the child prior to the age of majority, I believe such testing is permissible and should be encouraged. However, if the testing is pre-symptomatic testing, such as for late-onset malignancy or Huntington's disease, I believe that testing should be prohibited until the child reaches the age of majority or reproductive activity and can give their own informed consent. Even though an individual may not be 18, the knowledge may influence their reproductive behavior. In the case of collecting a specimen for linkage analysis to benefit another family member, the testing could be assented to if no results of that child's studies were shared with the parents or other families or the child until they could provide their own informed consent. Parents may also wish to test their unborn children through prenatal testing. I have no quarrel if the tests are to provide relief, clear the air, or help the family prepare for what may be ahead. But the presence of genetic disease is not sufficient grounds for the termination of an innocent life through abortion. What a blasphemy separation and genetic testing in conjunction with in vitro fertilization. If some of the embryos had a genetic anomaly and others did not, should we not implant those embryos without the genetic problem? Now, a full discussion of the moral questions raised by in vitro fertilization is beyond the scope of this talk. However, I will state that there is a parental obligation for the implantation of all embryos, all viable embryos created. As such, genetic discrimination between embryos becomes moot. The fact that there are often more embryos created than can be reasonably implanted is not sufficient reason to condone pre-implantation testing, but is a point that raises serious concerns about the moral acceptability of some in vitro fertilization practices. Many centers are capable of this type of testing, and as Christians, I believe we must condemn the practice. I share with Dr. Collins the concern we may not practically be able to prevent it, but we can prophetically oppose it. Genetic testing presents us with amazing resources in diagnosis and the potential to alter the natural history of some diseases. In other cases, our new knowledge may predict the future but not enable us to do anything about it. Dr. Collins quoted Oedipus last night, "It may be but sorrow to be wise and wisdom profits not." But let us humbly go before the Almighty, seeking his wisdom, which in contrast to our own is true, is light, and is always profitable. Thank you.